This film demonstrates a laterally positioned flap to cover the denuded root of a mandibular central incisor. There is recession present with loss of attached gingiva. The probe indicates that the gingival margin is made up of alveolar mucosa, which has retracted from the tooth surface. The inferior labial frenum continues to pull on the mucosal margin. Pocket depth is present, and the area is constantly inflamed. Continued recession or deepening of the pocket will result in the loss of this tooth. This gingival tissue, therefore, must be replaced. The adjacent central and lateral incisors have gingival tissue which could serve as donor sites. The involved area has been initially prepared by scaling and root planing. The occlusion has been adjusted and the patient instructed in oral physiotherapy. After infiltration anesthesia has been obtained, vertical incisions are made with a scalpel to remove the inflammatory tissue on both sides of the cleft. A horizontal incision is created at the base of the cleft. With the Goldman Fox number 12 curette, all the loosened tissue adjacent to the cleft is removed. The area is irrigated and carefully inspected for residual soft tissue tags, calculus, or debris. A vertical releasing incision is made at the distal end of the donor flap from the margin into the mucosa. The scalpel blade is slipped under the mucosa and a sharp partial thickness dissection is carried toward the gingival margin. The use of a partial thickness or a split thickness flap enables the clinician to leave periosteum on the donor site, which does not denude the underlying alveolar process. Healing is facilitated because the periosteum covers the bone, and some of the fiber apparatus is left embedded in the cementum of the teeth. The dissection progresses from an apical to a coronal direction. Care is taken not to perforate the flap with the scalpel blade. Obviously, a periosteal elevator could not be used because a full thickness flap would expose bone at the donor site. Prior to positioning the flap, the root surface is lightly planed to remove any remaining necrotic cementum and debris. A Goldman Fox number 12 instrument is used. The mentalis muscle fibers are relieved by sharp dissection from their attachments to the periosteum. The attachment of muscle fibers is thereby relocated to a more apical position. The planing of the tooth surface adjacent to the cleft permits some exposure of the periodontal ligament fibers that extend from the tooth to the interdental bone. It's felt that the proliferation of tissue from this site enhances the repair of the laterally positioned flap. The flap is reflected and brought into position at the recipient site. A slight cutback incision is made in the mucosa to relieve any tension that exists on the flap. A 6/0 black silk suture with a reverse beveled atraumatic needle is placed through the corner of the flap that will be secured to the distal surface of the cleft. The flap is secured at this position. Sutures are also placed along the vertical incision, joining the pedicle flap to the gingival tissue on the mesial surface of the lateral incisor. The suture is then placed around the lingual aspect of the adjacent central incisor. The needle is inserted through the mesial corner of the flap and carried through the interproximal space between the two central incisors to the lingual side. The suture material is brought around the lingual surface of the central and lateral incisors of the adjacent quadrant and secured on the labial aspect. This suturing procedure brings the mesial corner of the flap against the tooth and helps to cover the interdental space between the two central incisors. A piece of telfa is placed at the donor site and covered with the bare Sumner pack. An outer dressing of the modified Kirkland formula is also used. Both labial and lingual surfaces are covered with these dressings. To help retain the dressing, adhesive dry foil is placed over the Kirkland pack and carried on to the lingual surface. The area is kept covered for 1 week. The sutures are removed at that time and the pack replaced for a second and possibly a third week. This is the site 5 weeks after the surgical procedure was performed. Note that a band of gingiva is present on the previously denuded root. Probing at this time should be performed rather lightly. Retraction of the lip demonstrates that the frenum is no longer retracting the gingival margin. The laterally positioned flap will now be used to replace the lost gingival tissue on the mesial buccal root of this maxillary molar. A pocket is present, which extends into the alveolar mucosa, and recession has occurred due to faulty toothbrushing habits. Since there is minimal sulcular depth on the buccal surface of the second premolar, this will be the donor site that will be used to cover the mesial buccal root of the maxillary first molar. After infiltration anesthesia has been obtained, a vertical incision is made on each side of the involved root. These are joined, and the soft tissue bordering the pocket is removed. The number 12 Goldman Fox instrument is used to plane the root surface and prepare the root for the laterally positioned flap, which will be taken from the second premolar. Since there has been recession on the distal buccal root of the same molar, it will not be possible to position the flap in a more coronal direction than the height of the gingival margin on the distal buccal root. A vertical incision is made at the anterior border of the flap at the distal buccal line angle of the first premolar. Recession has also occurred on the canine and premolars, so there has been some loss of gingiva on these teeth. The interdental papillae are separated from their lingual halves. A partial or split thickness dissection is carried out in order to leave periosteum at the donor's site. This will ensure that no unnecessary exposure of the underlying bone will occur. The flap is released from its underlying attachment. Note the absence of any exposure of bone on the second premolar. Soft tissue covers the underlying alveolar process. The muscle fibers are severed at this time to permit more mobility and facilitate the positioning of the flap. The flap is positioned over the root. Its distal corner is sutured to the mesial aspect of the gingiva on the distal root and tied. Additional sutures are placed along the distal margin of the flap. The mesial margin is secured with a tissue adhesive, isobutyl cyanoacrylate. This material has been provided by Ethicon Incorporated in Somerville, New Jersey. The entire area is covered with a bare Sumner pack and reinforced with a pack of the modified Kirkland formula. The pack is locked interdentally with college pliers, and the area is covered with adhesive foil. At the end of 1 week, the dressing is changed. Sutures and any remaining isobutyl cyanoacrylate are removed. The area is redressed for a 2nd week. The objective of this laterally positioned flap procedure is to restore gingiva to the surface of a tooth where it has been lost by periodontal disease. The operative site 5 weeks later shows that there is gingiva present on the mesial buccal root of the first molar. The donor site on the second premolar has healed well. Probing demonstrates that there is a shallow sulcus of 1 millimeter at the donor site and 1 1/2 millimeters of depth on the mesial root of the first molar. Muscle pulling shows the cup of gingiva is not retracted from the tooth.